And you mentioned the nociceptive receptors before, right? Which transmit pain up into our brain. But one thing that I found is that the degree of activation of nociceptive receptors doesn't actually correlate to people's subjective experience of pain,
Right.
which tells us there's got to be something else going on.
Right.
You know? What do you think?
Yeah, well, I think that's a yes, and when we're talking about this acute versus chronic pain, because it is complicated. I'm glad we're spending time on this because all experiences of pain are shaped by that circuit you outlined earlier with your emotion, your memory, and throughout the spinal cord as well as the brain. That's true of every experience. That's why people have different pain thresholds. But there are some experiences of chronic pain where it's really not coming from those nociceptors. It really is coming from the brain.
Yeah.
And that's the kind that we can really completely eliminate with a brain-based intervention like psychotherapy.
Yeah.
Welcome to the Better Brain Podcast, where we talk about all things brain health for anyone who has a brain or knows somebody who does and wants to make it better.
Today's guest is Dr. Brandon Yarnes. Dr. Yarnes is a geriatric psychiatrist at the LAVA. He's section chief for geriatric mental health and an assistant clinical professor in UCLA's Department of Psychiatry. His recent publication in JAMA on a new treatment for chronic pain is absolutely groundbreaking.
We get into that study and how it differs from other therapies that have been given for so many years and really just didn't have as big of an effect as the therapy that he studied. Plus, we talk about the basics of pain, what it is, where it comes from, and how it becomes chronic, and then how to treat that.
Yeah, and I think our conclusion was pain starts in the brain and ends in the brain. Let's get into it.
So, Brandon, we're excited to have you today. It's a critical topic, pain, and to so many people, particularly relevant to a group that I work with, the Wounded Warriors at Operation Mend. I'm telling them almost every week in these pain groups, look, knowing pain, understanding it is a therapeutic target in and of itself. And it's awkward even me saying that because I'm thinking, growing up in the era of Rocky Balboa, no pain, no gain, right? And you have these ideas that the pain that you feel is in some way getting you somewhere, right? But if you look at some of the data that's coming out, and one of my favorite pain neuroscientists, Lorimer Moseley, will say, no, it's no pain, no gain, with a K and O-W. Knowing pain, understanding the neuroscience of pain can actually benefit you, can actually allow you to know gains in control over pain. And so, thinking that way, I'm thinking about how can we know pain better? How can we teach our audience and the warriors that we work with across the age spectrum about pain? What is it? Where does it come from? And why? And I think Dr. Raffi here has a philosophical point of view.
No, I don't. It's not necessarily philosophical. Just looking into this, into pain, into chronic pain, especially leading into this episode, I thought about sort of the timeline of pain, right? Like, where were we at the beginning of time, and how did we think of pain at the beginning of time? And you think back in ancient Mesopotamia, when they used to think pain was like a divine punishment, and we think about how far we've come there. Then, we progress to the humoral theory, right? So this imbalance of bodily fluids, that's the reason for your pain. And then we progressed eventually to the gate theory, right? In the 1960s. And then we're at where we're at now in terms of how we think about pain in this biopsychosocial model. So I want to get your thoughts on what you think about where we were then and where we are now, and maybe where we're going in the future.
Absolutely. So what's interesting, a lot of people think that if you just pinch your finger or you touch the hot stove, that's usually the example people give, that it's just a simple circuit, that's a sensation, you're going to feel pain. And it's not that simple at all, actually. All pain is processed through the brain. And so in order for my finger touching the hot stove to feel pain, it has to go up to my brain, a signal, and my brain determines whether I will feel pain and how much pain I'm going to feel in my finger. And people can have strokes, or they can have really terrible brain congenital conditions and not be able to feel any pain. And so it really is the brain that's the organ of pain, and that's what the latest research, I would say, is really showing us how important that is.
I came across a condition, I forget the name of it now, but where you can feel pain, but you don't have any sort of emotional attachment to that pain. Do you know the name of that?
I've heard of that one.
You've heard of it?
Yeah, I'm not. It's not coming to mind right now. But
Yeah.
But it's really is those emotional brain centers in healthy people and patients with chronic pain that are activated in all experiences of pain. So inside the brain, it's not just a sensation, but it is always an emotional experience as well. At least that's how it looks like. That's how the brain lights up with experiences of pain.
Yeah. And
I mean,
Yeah, go ahead.
just to take a tangent or a little trip down some data on actually what the brain does when it's experiencing pain or generating a pain experience. You can see in a functional MRI study just depicted as representative images from this lab at Duke. There's several regions in the brain that activate when an individual has some tissue trauma or tissue stimulation that is aversive. And in the condition of chronic pain, there are many more regions that take up and produce that experience. Several of them are overlapping with regions that produce emotion. And so I always show images like this when I'm trying to help people understand, look, going through pain is an interfering, a distracting process. It steals resource from key areas like the frontal lobe that's trying to multitask, pay attention, remember the current moment, and be able to be witty and interact with other individuals. If you're having in the background chronic pain, there's a whole lot of real estate dedicated to processing that.
And back to the timeline of things, despite the humoral theory or all these other theories that seem ridiculous to us now, it seems like there was always a sense, at least maybe in Roman times, that the mind had something to do with it. The brain had something to do with it. And, I really enjoy reading Marcus Aurelius, and I got this quote from him, which, you can see up there. It states, "If you are distressed by anything external, the pain is not due to the thing itself, but to your estimate of it. And this you have the power to revoke at any time." What do you think about that?
Well, definitely the first part speaks to me, that pain is not due to the thing of itself, but it is an internal process inside of us, inside of our brains and bodies. And our brains are shaped by our life experiences and what's happened to us before. And that affects how much pain we feel with a certain stimulus, whether it's a hot stove or whether it's a disc bulge in our backs. So that part really speaks to me. And the second part about the power to revoke it, my whole work in doing psychological treatments for chronic pain, it does support that notion, but I don't want anyone to walk away from that quote thinking it's easy or it's straightforward or it's a simple mind over matter. But I do think there's something to that part to do it, that we have more agency to affect and influence our experience than maybe we might think when we're stuck in pain.
Yeah.
If you don't have that mentality at all, it's harder probably.
Right.
So having some of this stoicism, that he speaks about is probably better than not. But I assume there are certain circumstances, and I've gone through them myself, I'm sure every human has, where you cannot revoke the experience you're going through. I mean, even illusions themselves can be tricky for the brain to evoke, even though it is an illusion and it's fake, or it's not proportionate to what you're actually experiencing.
Yeah.
So why don't we kind of get back to the beginning of the story and zoom back out. You started to talk about pain and what it actually is, and where it happens. You said it happens in the brain. So just walk us through what is a formal, good definition where we can start.
Yeah, so there is a definition by something called the International Association for the Study of Pain. They actually come up with a definition of pain, and it is both a sensory and an affective or emotional experience that's in response to actual tissue damage, if I actually burn my hand on the stove, or potential tissue damage, the threat of tissue damage. So there is that definition, and it's complicated, right? And it's influenced, like I said, by lots of our life experience and who we are as a person, as to how much that experience is going to affect us.
Yeah. So one point you're raising is it's not universal. If everybody got the same amount of cold on their hand, the same amount of pressure on their fingernail, the same amount of heat on their arm, it would be experienced differently. And maybe if you put them in a functional MRI scanner, the brain areas that are involved would light up, maybe more real estate would light up, or more intensity of blood flow to those areas would occur. And so it's a really personal experience.
It is, yes. And so there, we actually sometimes do experiments in the lab where we induce pain, to test what happens in the brain, or to test a drug or a treatment. And the first step always in those experiments is to determine an individual's pain threshold, because everyone has a different pain threshold about how much pressure or how much heat it takes to be painful to that person, and exactly how they're going to react and process that experience.
What do you think influences someone's pain threshold? Genetics, environmental factors, nature, nurture? What do you think?
Yeah, I mean, that really is a big nature nurture point, but it really is, my stance is this, as somebody who's a psychotherapist, that's primarily how I identify, that our course are influenced by our genetics. We can't avoid that. I mean, you're both taller than I am today. I noticed when I was coming in, but that's genetic. The thing is, there's not much we can do about that today in terms of the technology that's available to us. And so there is also a huge component, as much as you want to believe, there is a huge component of the nurture side, our life experience, whether we've had trauma, whether we've had a lot of stress in our lives, the specific kinds of experiences we've had and relationships that we had, our whole growing up and where we are today, all of that, and the way we learn to cope, the way we learn to manage stress, the way we learn to deal with life and its inevitable pain is going to affect our experience, and that's where we can maybe have an effect with helping people.
Yeah, it's very interesting. So you're saying that, or you're implying that maybe history of trauma, adverse childhood experiences might influence our pain threshold?
I do think that there's evidence of that, and yeah, I've seen for sure different people's way of dealing with pain growing up or having pain inflicted and how that was handled. For instance, I had a patient that he fell and broke his ankle one time while he was riding his bike, and the other kids went home, told his mom about it, and she said, I don't know. So he had to push his bike all the way up the hill, and his mother looked at it, yeah. It didn't take him to the doctor till the next day, and then finally it was swollen up this big. They did an x-ray and said, yes, it's broken. Right? And so growing up, how do you learn to care for your own experiences of pain that happen throughout life, after having experiences like that as a child?
Well, it reminds me of our conversation with Bessel van der Kolk on our episode. He wrote the book, The Body Keeps the Score, which I'm sure you know. And he said, look, it's not just stress that overwhelms the individual's capacity to cope in that moment that leads to a post-traumatic stress syndrome, but it's it's experiencing that with neglect, with a feeling that there's no one else there to help,
support system,
or support you.
Yeah. I would like to circle back to that, though. So in that circumstance, would you say this person's pain threshold in the future. Certainly there's other factors, but for this case, would you say their pain threshold would be higher or lower because of that situation?
Well, yeah, I don't know how it directly affects their pain threshold, but there is a part two to that story.
Okay, yeah.
Because when he was working in a warehouse, there was a pallet that fell on his foot, the same foot. This is what makes it such a crazy story. And he reacted the same way his mother did in being in high pain. So his pain was still there. I don't know how it affected, pain threshold for him in his case, but the way that he cared for that pain was also to kind
Sweep
of
it under
not
the
get
rug.
help and sweep it under the rug. And then a couple of decades later, he's still coming in to me with chronic pain as a consequence of that experience. So the pain somehow stuck with him his whole life.
So this is interesting because, there might be a perspective that might look at that situation and say, well, you're building resilience in that person and you're building this mental toughness. If I wouldn't know the outcome, or if they wouldn't know the outcome, the fact that they're seeing a psychiatrist for chronic pain now in that foot potentially. But if we didn't know the outcome, then we might think that that person is tougher, more resilient because they don't immediately go to the ER or immediately worry about their foot so much. What do you think about that perspective?
Yeah, I mean, some people might think, oh, well, this person may have a very good high pain threshold. They're really tough.
Right.
But I don't know if you really stop to think how many of us would really believe that. If we're talking about, if we picture a child, a 7-year-old fell off his bike and is sitting there probably crying. I mean, is that really toughening him up? Is that really the priority there?
Yeah.
Or no, is he more likely to actually grow up and be able to overcome things if he's taught at an early age that it needs to be cared for and time needs to be taken to heal this injury for you then to be able to overcome it and move past it?
Well, I think it's an incredible example, especially for men who have the societal and cultural norm to sweep injury, pain, discomfort under the rug and demonstrate to everyone around them that they are tough. And then years later, that starts to cause overuse injuries and actually doesn't have the same benefit as it used to. And I see this in the Warriors all the time, where special ops folks will have had the capacity to push through experiences that we couldn't even imagine, and that worked for them, and that got them to where they got. But now on the tail end, they can't still live that same life. They can't still pull that tool, the no pain, no gain, the endure, out of their toolbox and use it universally in all aspects of life. They actually have to start having self-compassion and listening to their bodies. Not that I'm good at it, but we both address, I think, in these conversations I have with them, that this is a hard and new skill to learn, listening to the body and using that as a cue to care for it.
Exactly, yeah.
Which is unnatural in many people, I think.
Because as much as we were talking about the brain being the primary organ of pain, I mean, yes, if you continue to push yourself too hard and don't take care when your body is when you are getting that signal from your brain, from your body to slow down and stop and take some more care, then yeah, you can hurt your body at that point. So yeah, it's definitely complicated and tough.
Also, just different types of pain. I've heard in the animations that we'll share in the resources in the show notes on key and fundamental components of pain that I think are misunderstood. One is the pain neurocircuitry, or I forget exactly what it's called. Another group calls it the neuroplastic pain type.
Right.
And so maybe we can elaborate on that or talk about the different types of pain so that we can understand what is it we're dealing with.
Sure. So I do think it's a good place to start with distinguishing acute pain and chronic pain. So acute pain would happen when you broke your leg or when you broke your foot riding your bicycle. And I'm not, as a psychiatrist, recommending psychotherapy for that, obviously. Okay, so just so we're clear, but the key about it is there's obviously an injury in the body. That's what we're talking about. Or touching the stove, there's potential for injury in the body. What we're talking about when we get into more chronic pain has a fuzzier definition than the definition we gave for acute pain earlier. Chronic pain is just pain that lasts longer than 3 months. That's usually how it's defined. And so why 3 months? It's because the body has a remarkable ability to heal itself. So if I did break my leg and a doctor set that and put it in a cast, within 3 months, we would actually expect that to heal, right? That's why there's that 3 months. But in fact, it's more complicated than that. And we find in chronic pain, there are different subtypes, we call, of chronic pain. In some types, there is ongoing injury in the body. A really clear example of this is someone with cancer pain. If you have a tumor that is continuously damaging your body and causing your pain, then there's an ongoing injury. So it did not heal in the 3 months as expected. That's one type of pain. We sometimes call that nociceptive pain because nociceptors are the pain receptors in the tissue. This other type of chronic pain you're referring to is called various things. So the ICD, which is a system of classifying diseases, they have a term primary pain in their most recent classification. There's also psychophysiologic pain, centralized pain, neuroplastic pain, nociplastic pain, neural circuit pain. So it's not very good on the messaging here but in that category of pain, there's really not an injury in the body that can fully explain a person's pain. And so the kind of the premise or the hypothesis that we have in dealing with a patient where there's not clear evidence of an injury in the body is that pain is actually maybe generated by the brain. So it's actually coming from their brain primarily, the pain. And that is the kind of pain that really we can address with psychotherapy and not just manage that type of pain, but completely eliminate it, help patients get rid of it.
So an analogy that I'm thinking about, and maybe to help myself as well as someone listening to you understand, is phantom limb pain.
Very
Do you
good,
think
yeah.
this is a good analogy?
I do.
Yeah.
Yeah, because phantom limb pain is pain in a limb that is not there.
Right.
I mean, it's not on the body, it's been amputated.
Right.
And so obviously there can't be any damage or dysfunction in that limb which is not there. So where can the pain come from? Are we saying the patient is making it up or lying or exaggerating or the pain is not real? No, we're not saying that at all. The pain is very real. It's just probably created by the brain, right? And so it's coming from a place in the body, which is the brain, that's different from where the person's feeling it.
Yeah, but I think we're more liable to believe the patient, and I hate to say the word, the term believe because, it sucks, but the fact that we're more liable to believe someone because you can see is the person's leg is missing or their person's limb is missing, right? So you can see that there definitely was evidence of significant injury versus maybe some other cases like a herniated disc in the neck or the lumbar spine or something like that.
Where it's not clear anymore that there's ongoing damage.
So what you'll see with an MRI, there'll be a disc herniation, and then within 3 to 6 months, if you repeat an MRI or even a year, usually there's some level of resolution of their herniated disc. But they're still exhibiting very similar symptoms to how they initially presented with lower back pain plus minus radiation into the leg.
Yeah, so back pain, I think, is a really particular case, a really interesting case, because if you take an MRI, so I mean, I treat mostly older adults. I'm a geriatric psychiatrist, And so like my average age of my patient may be 70 years old. So if you take an MRI of a 70-year-old's back, you are going to find all sorts of abnormalities. Degenerative disc disease, 93% of 70-year-olds have degenerative disc disease, or disc bulge, bulging discs. Everybody's heard of those. And sometimes more complicated things like you're talking about disc protrusions and things like that. That's in 70-year-olds without chronic pain.
Right.
And so, again, it's often unclear from an MRI whether there is an ongoing tissue damage source
right.
of their pain.
Yep.
And so, my colleague Howard Schubner actually came up with some criteria to evaluate people with back pain, and determined that 88% have some evidence of this centralized or neuroplastic pain. That's really means the brain is playing a big role in nearly every case of back pain.
And what's that evidence?
And so he has it's a clinical assessment, and the clinical assessment looks at the characteristics of the pain. For instance, if you have a disc bulge at a certain spinal level, there's a certain spot where you'd be expected to feel pain, but the patient has pain over a large area of the back that couldn't be anatomically explained. Also, do they have other supporting, like circumstantial evidence would be additional trauma, depression, anxiety, PTSD, another collection of unexplained physical symptoms. And then he also has a list of personality characteristics, which he says are more associated with this kind of neuroplastic pain. It's more derived from the brain. And that's examples are like people pleasers, perfectionistic people. And these are really clinical assessments that he's made that he thinks are more likely to be associated with neuroplastic pain.
Yeah. I think I saw neuroticism as something that
Neuroticism,
a personality trait that predisposes. What do you think of the percentage of people that are living with chronic pain right now? Last I checked, it was 25% of Americans. I'm sorry, 23% of men and 25% of women. That's a lot.
It's bad, and it's not getting any better. I mean, I've also seen studies that show that the prevalence of back pain is increasing, actually, in spite of all of the attention that has been given to pain in the media and in medicine, in our field. And so I do think we need to rethink the treatment approaches that we've been using and the assessment approaches and the way we're talking about pain and the way we're speaking to patients and society about pain. I really think we do need a paradigm shift in our understanding of pain.
So that's going to be a great segue before we get into how to talk about it, because I think that's critical, is how we ourselves can understand pain and how to speak with loved ones or friends or patients with pain. But, other pain conditions that are particularly hard to wrap our heads around include fibromyalgia, complex regional pain syndrome. We already talked about phantom limb, but how can you help us understand those conditions that are difficult to treat, difficult to understand? We're still learning more about them. Where do those lie in terms of the pain types?
Yes, fibromyalgia is a diagnosis that a lot of people receive as a consequence of not finding a very clear physical bodily cause for the person's pain. And they feel pain, like I mentioned a moment ago, over large areas of the body, which anatomically is difficult to say that there's an injury somewhere if pain is in large areas, regions, left side, right side of the body, everywhere. And so we tend to think that most cases, if not all cases of fibromyalgia, fit into that neuroplastic category where they're primarily being caused by the brain. Again, not to say that people are making those up. That is their experience. They're feeling that pain and that burning and everything they feel, but the source of it is probably the brain. And with complex regional pain syndrome, that one's even trickier because oftentimes people come in and they may have swelling, or they may have, redness in the limb. This is a part, in case people listening don't know, that it's just like in one region of the body, usually like a hand or a foot, there's pain. And there can be like swelling and redness additionally. These are very difficult cases because it's not clear where the injury is. There's some sort of inflammatory reaction that's still ongoing in that part of the body. But we really feel like, again, where is the inflammation coming from? Why is there inflammation? That there's a big piece of that that's coming from the brain in those cases.
But let me push back a little bit. Fibromyalgia, I agree with you. CRPS, there's usually some sort of history of trauma to the limb,
Yes.
to some region around there. And there's, physiologic objective findings, right?
Yes,
in the limb,
exactly.
right? There's swelling, there can be discoloration, and there can be increased sweating or decreased sweating, even loss of hair in the area, right? So these are like objective physiologic findings in the area where they're exhibiting pain. Like, how do you
Yes.
parse that? What do you think?
Yeah, so I think it's true that if there are changes, right, we can't argue with that. But it's not the same thing as saying why there are changes, right? So the fact that there are changes doesn't speak to the cause of those changes. And so is the cause because there is some ongoing injury or disease process that is just restricted to one limb? Maybe, but we have bloodstream, we have a nervous system that connects everywhere. It seems unusual, but what can cause something like that is the brain, that it can lead to changes. The brain is involved in all of our hormones, all of our nervous system, as I mentioned, with the pain response. And so it's very possible that the brain can cause real changes to occur in the tissues of the body.
Yeah, I'm not doubting that. I have, what I have doubts about is it's unilateral. It can be unilateral. It can be in that limb. And then stellate ganglion blocks, right? Which are, stellate ganglion is a hub of our autonomic nervous system, sympathetic nervous system.
Sure.
Injecting
sure.
with anesthetic, decreasing that activity can actually help CRPS symptoms. So I do wonder, and the stellate ganglion is outside of the brain.
Sure.
So I do wonder, maybe it's something that we just don't understand because we haven't really figured out the underlying physiology and mechanism.
Sure, could be, yeah. I mean, I'm certainly not here to say every case of everything is one way or another. I think it's very important that we assess patients on an individual basis, and that we discuss risks and benefits of various treatment options and have them pick what they think, after getting all the information, what they think they want to try and what order. So yeah,
Absolutely.
I definitely see your point.
And at the end of the day, more tools is better.
I agree.
Yeah.
Yeah, totally.
So one thing I want to talk about and understand your point of view on is the gating theory, that we've got this ascending and descending components of the nervous system that are bringing signals up to the brain. The ascending one about tissue damage, inflammation, other things that might be a threat to the human. Through the spinal cord, let's say it was a tissue damage to my palm, it would come up through to the cervical spinal cord and meets another neuron there, communicates a message, hey, there's been a problem here in this location. And then that comes up to the thalamus and then out to the cortex through a series of neuronal communications. And eventually the cortex is privy to all the information accessible to it, everything that's going on from the five senses, plus organ information, interoception, plus memory of anything that's ever looked anything like it, or future worries about it, anything that could have to do with an injury to the palm, or given a set of circumstances, maybe it's shrapnel to the palm, in a car accident, I've still got to save the kid that's in the car. The context and all of this information about, prior history and future possibilities can then carry information down the descending pathway to that same area where it first entered the spinal cord with the, smoke alarm or that pain signal or trauma signal, and that can modify the signal going forward.
Right.
That's the theory. Is that real? Is that really happening? And if so, how do you leverage that in therapy?
Yes, well, I do believe in it. I think you have to in my business.
Right.
But yeah, and there's evidence everywhere, and I think a lot of evidence people know like commonsensically in a way without knowing all of the neuroscience
Yep.
that you just described. For example, there are reports like you mentioned of similar reports in soldiers who are in an area of danger and get shot or they get blown up, and they actually feel no pain because they're still in the combat zone and they've got to get themselves to safety or get their buddies to safety, and then afterwards the pain response comes. So we've been talking about how the brain may cause some kinds of pain, but it can actually alleviate pain in that way. And it's very complicated and it's out of your awareness. You can't just mind over matter it.
Right,
Again,
right.
that's not what we're
I
saying.
always say, unless you're a Buddhist monk or a Stoic,
Right. And
then
that's a
I don't know
full-time
how
job.
I don't know how you top down stop it, and nor would you
Right.
really want to. Pain at the most basic level, and this is explained in Tame the Beast, is our friend. You know, it is this thing
Yes.
that's supposed to help us survive and identify threats. And in the acute setting, that's really helpful. In the chronic setting, it becomes degenerative or destructive.
What about the distinction between pain and suffering? I think that's an important distinction to make. And thinking about this, I thought maybe chronic pain is just our medical terminology for suffering when we're trying to distinguish between the two. What do you think?
Right. Yeah, I have heard, I mean, you mentioned Buddhist approaches. I have heard a lot of the mindfulness treatment approaches that I've seen. They really teach that as a core aspect of the treatment, that pain, when they say pain, they're referring to more of those acute instances of pain, which are good and helpful and useless because you don't want to just keep your finger on the stove or you'll get it in trouble. And then the suffering is the part that is a whole constellation of experiencing pain and the effects of that, the effects on your mood and on your functioning and on your life and potentially your relationships, and that whole constellation of symptoms being suffering. Yeah, I think that's a great way of putting it.
I'll tell you a quick sidetrack story about kind of pain and the brain. I did the rubber hand illusion on Daniel the other day, and we filmed it. We'll put it out there soon. But part of the experiment is to associate a rubber hand that is not yours to your brain map of your personal space. And so as the experiment goes on and you map that rubber hand to a part of your body, you start to experience it as part of your body. And so if I threaten that rubber hand, you might generate a stress or pain reaction to it in some way. And so I threatened that rubber hand as the experiment went on with a flame. And we had heart rate on the screen, and it started to climb. And I threatened it with a drill, and I kind of, made it pretty dramatic, kind of moving that drill bit towards, spinning towards his rubber hand. And his heart rate kept going up. And then I slammed his rubber hand with a hammer, and his heart rate skyrocketed up to 110, otherwise resting. And then I did the same thing later on to his unseen real hand. So it was out of his view with a flame, a lighter, under his one of his fingers. And it was close enough that I could feel the burn on my finger. And his heart rate didn't move. He said,
Wow.
I feel the warmth, but that was it.
Wow.
And so the experiments go both ways in that particular illusion, where some show a dissociation of the real limb and some don't. But it makes me think about that classic example of a nail through the construction worker's foot,
Yes.
where the nail actually misses his skin altogether, but just spikes right through his shoe, end to end, it goes between his toes. Seeing it, he thinks it goes through his foot and has an entire pain reaction, goes to the hospital, and they pull it out and look, and his foot's got no scratch on
Yeah,
it.
they had to sedate him. He was in so much fear and pain.
Yeah.
So I don't think
Yeah.
it's an uncommon experience. I mean, that particular scenario I think is uncommon, but to feel pain based on the entire context, what your brain brings to bear. It can map a rubber hand that you then experience some discomfort in. It can feel pain because it looks painful. I mean, even watching people undergo pain lights up some of the pain matrix in your brain, some of the
Yes.
brain regions involved in pain.
Yeah, I'm so glad you did that, because when you asked me to send you
I'm glad I
a
did it
couple
too.
of things.
Yeah, you both are the only people glad at this table right now.
Sorry, but yeah, I thought about sending that video along, because
That's a great one.
that's so important. That notion, we just really underestimate what the brain can do.
Yeah.
I mean, we really underestimate its effect on so much in our lives and our experience.
And you mentioned the nociceptive receptors before, right? Which transmit pain up into our brain. But one thing that I found is that the degree of activation of nociceptive receptors doesn't actually correlate to people's subjective experience of
Right.
pain,
Right,
which tells us there's got to be something else going on,
right.
you know? What do you think?
Yeah, well, I think that's a yes, and when we're talking about this acute versus chronic pain, because it is complicated. I'm glad we're spending time on this, because all experiences of pain are shaped by that circuit you outlined earlier with your emotion, your memory, and throughout the spinal cord as well as the brain. That's true of every experience. That's why people have different pain thresholds. But there are some experiences of chronic pain where it's really not coming from those nociceptors. It really is coming from the brain.
Yeah.
And that's the kind that we can really completely eliminate with a brain-based intervention like psychotherapy.
Yeah.
You know, you have to think in most patients that have chronic pain, there's probably both happening, right?
Right,
And
right.
on top of both top down from the brain generating some experience that is a pain experience, even though there might be no nociceptive or tissue damage, right? On top of that, there could be acute on chronic, you know, so
Exactly.
the disc that once slipped is never, you know, as stable as it was before, and eventually, as the disc kind of resolves or the inflammation around it and the nerve is no longer pinched, the stability is not there, and maybe the individual had to take off months of work and working out and standing and all the other things that stabilize the spine in the first place, and so more susceptible to injuring that area again. And even with like probably less injury in certain individuals, the muscles, the nerve complex there, everything that's around that area that once was injured could be overactive.
Right.
Is that part of central sensitization? I know we talk about central pain versus other things, but is that the process?
Yes, and so it's people with chronic pain, often they have abnormal, like more intense responses to painful stimuli like you're talking about. And that's called hyperalgesia, like they feel more sensitive to pain reactions, or allodynia, which is they feel pain where most people would not feel pain, like with light touch, they feel a pain response. So really having that chronic pain and having those changes in the brain that come from chronic pain it can influence your pain experience in several ways.
So the allodynia and hyperesthesia that people experience in the context of chronic pain is secondary to changes that are occurring in the brain?
Well, yeah, that's what we have some studies, some neuroimaging studies that have looked at that. But yeah, like there are many processes in the circuit, but definitely the brain plays a role in that.
And these are usually patients not on opiates,
Well, I think
right? I mean, it's interesting to think about, you know, what are the changes that are going on in the brain? Is it from a chronic pain state? Is it from opiates? Is it from both?
Right.
You know?
So I think you're speaking to opioids, like that process also changing the brain and
Sure.
being on long-term opioid.
Yeah.
And so there can be sensitization of the pain experience with long-term use of opioids too. Yeah, absolutely.
And my understanding was also in opioids, there's changes that occur in the spinal cord too,
Yes.
where there's
yes.
upregulation of opioid receptors in the spinal cord.
Right.
And that might predispose people to hyperesthesia, allodynia as well.
Yes.
Yeah.
Can we? I would love to talk about placebo effect. I didn't plan to, but it's one of my favorite
It is a
topics.
good topic.
There's two things I want to say. One, I'll give a shout out to Tor Wager's work in neuroimaging of the placebo effect, trying to understand where in the neuroaxis, in the brain stem, in the spinal cord, can placebos actually have an impact on the experience of pain or processing of trauma? And then two, not just an expectation in a cream that should, numb the arm to heat stimulus, or a pill that should, relieve a painful experience, but having an individual next to you that you're familiar with versus an experimenter that's with you in the scanner can actually increase your pain threshold or reduce your pain experience of the same stimulus. So these things speak to the context around the individual as generating a pain relief experience. What do you think about the placebo effect?
Well, historically, the placebo effect refers to non-specific factors. So it's like everything that affects a treatment outcome that can't be explained specifically through a specific mechanism. But yeah, I do think a lot of recent work, like you mentioned, Torwager's work, it shows that it's the central nervous system. It really is the brain and the spinal cord that's playing a role in that added benefit. So your beliefs then, psychological processes like your beliefs, your emotional activation, your emotional connections, these kinds of inner mental processes and emotional processes can affect your treatment outcomes. And then all of those together, the psychological side and the neuroscience side and the central nervous system, those are probably the forces that are coming together and causing what we have called the placebo effect.
What about, have you been able to identify any protective factors psychologically against developing chronic pain?
Yeah, that's a great question. And so, yeah, I haven't done any studies on people without chronic pain yet. Actually, everybody who's been in my studies have had chronic pain. So I feel like I know more about them than people without chronic pain at this point, scientifically. But yeah, I've seen what helps people get better, what helps to really get people out of chronic pain. And I think it is being able to accept yourself, the kinds of things we've been talking about with self-compassion, being comfortable with your emotions, being comfortable with your experiences a lot more, and broadening that experience so that you can be feeling a whole range of things and not just feeling pain all the time. Those are a couple of things.
What about self-efficacy?
Self-efficacy absolutely is very important, because a big part of the treatment we do, which we'll be talking about, emotional awareness and expression therapy, EAET, is helping the patient get agency over their own experience. And we do that first in the sessions together with the patients, seeing that you can influence how you feel, right, when we do various things in the session. And we've seen that can extend into every aspect of the patient's life, so that they can get much more efficacy in their relationships and in their activities and in doing what they want to do and what they value to do in their lives. I think that's really important.
We talked about it before we started recording. I just want to hit on this too, the intersection between mental illness and chronic pain.
Yeah.
I mean, I don't think it's something that we should ignore. It's there, it's prevalent. The numbers that I saw was 50% of patients with chronic pain have some degree of anxiety or depression. Maybe you've seen numbers different. Can you just speak on that big overlap and big correlation?
Yes, I mean, there's a huge overlap, and I would not be surprised to see 50%. I saw a recent paper, a meta-analysis, which is like a study of studies from earlier this year in 2025, that showed 40% of people with chronic pain have depression, 40% have anxiety, so maybe collectively it would be 50% have some sort of symptoms. These symptoms are also, like chronic pain, becoming more and more prevalent in our society, particularly among young people, and they often run together with chronic pain, and especially that kind of centralized or neuroplastic pain that we were talking about.
Are you seeing an uptick in chronic pain in younger patients?
Well, I don't personally see a lot of patients, but I think the studies show that the prevalence is on the rise of many types of chronic pain, unfortunately.
Wow.
Yeah.
Incredible. But why is that? Why is it so, anxiety, depression, why is it so interlinked with chronic pain? Like chicken or the egg? Is it the anxiety, depression? Is it the chronic pain? Is it both at the same time? Like what is it?
Yeah, well, we were talking about the brain and its critical role in chronic pain, and particularly those areas involving emotion. These are some of the additional regions that are recruited with chronic pain, like the graphic you were showing. And these areas, many of them overlap with the same areas that have altered function with depression, anxiety, with PTSD. And so consequently, we think a lot of these things are occurring in the same or similar regions of the brain. And those changes in those brain can produce different symptoms in different individuals, but part of this same kind of complex of symptoms. And I think it's interesting about the chicken or egg question, as I've seen data that many patients, well, let me say many patients say to me, well, I'm depressed because I have pain. I'm depressed about being in so much pain, which makes total sense. But at the same time, I've seen data that there's actually more likelihood to have like something like depression and anxiety, or excuse me, something to have fibromyalgia after being diagnosed with depression and anxiety. So that actually the pain condition can follow the depression and anxiety onset. And so these things are so like intertwined with each other in so many people and in the brain. We see it clinically, we see it in neuroimaging studies. It's very important.
Do people ever see the severity of mental illness track along with the onset of chronic pain, or does it not really matter how bad the mental illness is?
Yeah, one thing we do with patients is looking at stressful events in their lives and the symptoms that they have, which, people have a variety of symptoms. People could have chronic pain and mental health symptoms like you're talking about, or other kind of unexplained medical symptoms. And we ask them to put all of those together on a timeline so they can see in their life, what the progress has been and what, if any, looks like there are relationships on the timeline between these symptoms.
That's probably a very powerful exercise.
Oh, yes, yes.
Putting it on a timeline visually, showing yourself how things track from a temporal perspective. Yeah. So let's get into the study. I think it's a good time.
Let's do it.
Yeah.
Why don't you tell us a little summary of the study, why you started it, and then we'll kind of dig into some of the details.
Sure. So I'm a psychiatrist who's always been interested since I was in my training in psychotherapy. And I was actually learning a type of psychotherapy, which is a mouthful. It's called intensive short-term dynamic psychotherapy, ISTDP. And it's been used a lot in chronic pain, but also it treats other conditions like depression, anxiety. It's been used for personality disorders, actually. And the thing about it is that the sessions are video recorded, and you can see the actual ISTDP sessions.
Interesting.
And I saw some of these. One of my attendings when I was a psychiatry resident was learning this therapy. We saw some of his sessions. It's very powerful. It is, as the name would suggest, intensive. It's emotional. People have said it's like what you picture psychotherapy as, like these powerful experiences that people have that can like really help them to move and change.
Yeah.
And so the thing about it, I was learning that, but there's not a lot of clinical trials at the time I was in my training that show the traditional like evidence base for psychotherapy for ISTDP. And I wanted to do that. Like I wanted to study it and generate that evidence base. But it's not a time-limited treatment. It's focused on lots of different conditions. It's difficult to fit into that randomized clinical trial framework. So I was going to develop something myself, and I did a research fellowship here at UCLA just to figure out how to do that. And at the time, I met Mark Lumley and Howard Schubiner, and they had developed this thing which they called Emotional Awareness and Expression Therapy, EAET. And it was a manualized, time-limited. It started out as 8 group 8 weekly group sessions focused on chronic pain, helping patients with chronic pain. And they had gotten a large R01 grant to study this therapy in a clinical trial. And that's what I wanted to do. The thing about it was their trial was in fibromyalgia, and I wanted to apply it to my patient population of older adults who are veterans. And so I kind of adapted EAET for older veterans who are majority male. In Mark's study, they've been majority female patients. And so that became this study. I received a career development award from the VA to do a clinical trial comparing this EAET to the standard treatment, cognitive behavioral therapy for chronic pain in older veterans with chronic musculoskeletal pain.
Can you tell us what both of those would have looked like, both types of therapy?
Yes. So EAET, I have a slide on it, actually. So the goal, and it's great. I just made this slide Monday. I mentioned to you earlier.
Perfect.
But the key therapeutic task is along the bottom. And every session we do this. It's really one major intervention that we do every session that is supplemented by like the timeline and some written exercises and lessons on emotion and the brain and pain and things we've been talking about. But this experiential component here is very important. I think you just bring up the whole thing for the basic procedure. So first we get the patient's pain level on a 0 to 10 scale and say, okay, let's just make note of that. So your pain's a 7 right now. Now let's pick a hurt from your life. Now, what are we talking about with that? We're talking about a conflict they had with somebody recently, a stressful event from their lives, or people can get big into trauma. Like they can be assaulted, raped. We've done all sorts of big and small stressors or a hurt. And usually we start with something small at the beginning of therapy. So it could be like a guy cut them off in the parking lot and took their parking space this morning. And then we process this sequence of emotions that you see in the middle there. So this comes from basically from ISTDP, that there is a series of emotions that we all need to go through when we are hurt, when we have a trauma or a stress. And so is there anger, healthy anger about it? If somebody hurts you, this is protective mechanism as well as pain, right? The anger, healthy anger says, no, that's not right. I don't deserve to be hurt, right? That helps, that sense of healthy anger helps you value yourself. Then the second one is guilt. If you played a role, right, in this hurt, right, if you did something maybe, and if you allowed your anger to come out, right, like if it was a little old lady that got your parking place in the parking lot and you yelled at her, or you cursed at her, then you feel, oh, getting that guilt. And that guilt is really important because it can lead to healing. Because it's like, okay, I'm going to let it go. Ma'am, you go ahead and take this parking place. But it usually also leads to a sense of sadness that you were hurt, right? And a sadness that this happened, right, at all. And getting in touch with that sadness, especially when we're talking about things that happened to you earlier in life, like my patient that fell on his bicycle. Feeling sad for himself that happened to him, that hurt happened, leads to a sense of self-compassion, which I'd say is what we're trying to get to ultimately. But it's hard for our patients, it's hard for maybe all of us to go directly to self-compassion, just be compassionate toward yourself. So we feel like we need to go through this process to name and tame all of these feelings, to open the patient up, to open ourselves up to getting compassion, and maybe if it's an interpersonal situation, compassion for the other person too.
How do you achieve that in a group setting?
Yeah, so it really is a lot of working with one patient at a time and taking the time that a patient needs to go through this process, which is difficult because we have people getting worked up, getting angry, people crying in the session. I mean, we're trying to facilitate powerful emotional experiences. So we need time for that. In a group, like a group of veterans that have that shared identity,
Yeah. Camaraderie.
there's a lot of support. I've very rarely been in a group, it happens sometimes, I've very rarely been in a group where they're not extremely supportive and loving and caring. And so if somebody's struggling with, well, should I have been angry that I was assaulted? I mean, maybe I shouldn't have been there at that time. The other group members can come in and say, no, of course you could have. That shouldn't have happened to you. My gosh, of course. So it helps get that sense of righteousness, that sense of it's okay to feel the way that you do feel. So I think it really sometimes, most of the time, helps in a group.
Yeah.
So then when we finish this, we get a pain level at the end, and we hope it changed a little bit, half a point, quarter of a point. And then we're able to show them that, like, you can change your experience, you can influence your experience, right? With your own attention, with doing this procedure, this is something you can use to process your pain, hopefully to release some of the pain from your life, right? And if their pain goes up, then we say, well, that also proves the point, right? That your pain is influenced by your emotions and your brain.
Yeah.
Right?
Incredible. That's awesome.
And so then that's the debrief at the end. It's
Yes.
like, what does this all mean to you and your experience?
And what is your experience? Do most people's pain move?
Yes. Most of the patients, the pain moves. The thing is, not everybody's does. That's another advantage of doing it in the group. Because if there's somebody that's a skeptic, somebody that's being a little, putting up a wall, they will see the other members of the group who may have more buy-in and may be benefited from this process, may be transformed in some cases by this process, and that hopefully will help motivation. The last group we did, there was one man that he wouldn't go there, wouldn't do this until the last session. And session 8, he had big cry. And at the very end, we were like, okay, how was that for you? And he said, well, I think maybe there is hope. And that was so powerful. It gave me chills to hear him say that. But only by being in the group, I think, could he have gotten there.
Yeah. Incredible.
And the pain level that they're rating is body pain, all over pain, back pain, knee pain. A lot of these veterans have multi-joint musculoskeletal pain.
Yeah, something we haven't talked about is emotional pain. What is that? Is that a thing? And what we put forth, actually, and over the course of therapy, we hope by the end of therapy, the patient buys into this, that there really is no difference. Pain is pain. You can feel it in your heart. You can feel it in your back, right? It's pain. And so we try to encourage them to give a pain level, one pain level. What is the pain that you're experiencing right now? And that's kind of the way
Where do people
that we
tend
work
to
with
be?
it. Where do they tend to be?
Yeah, above 5?
Yeah, the average in the study was over 6. That was the average pain at the beginning of the study.
Fascinating.
Yeah.
Incredible.
So you did that, and over the 8 sessions, that's what it looks like, but you're increasing the intensity of the experience that they're describing.
Exactly, yeah. So we do that pretty much. That's the core of the 8 sessions, also with some educational pieces and some written homework.
What's the homework?
So we have exercises. Mark Lumley, who was one of the developers of this, he's done a lot of work on writing for emotional processing. So there are exercises like an unsent letter. So we say to the patients, if you're hesitant about sharing a big emotional experience, big conflict that you've had with somebody in the group, another thing you can do is write the letter. And an unsent letter, you write it for yourself to get your feelings down on paper. You don't write it for the other person. When you write it, you can burn it afterwards, whatever you want to do with it. You don't have to send it to anyone. So that's another example. And the timeline that I mentioned to try to understand how stress and emotions and pain and symptoms have interacted with each other across your
It
life.
seems quite experiential rather than so cerebral or cognitively focused.
That's right.
You're
Yeah.
having them go through an experience, putting words to it sounds like also, but where I think the challenge is, and maybe you're going to explain how this differs from cognitive behavioral therapy, but is that talking about it and trying to talk yourself out of this experience that my knee obviously has some damage to it, and that's why I'm experiencing pain there, rather than it's somewhere in my brain that's, somehow
Right.
transmitting a signal down or in some way transplanting an experience to one part of my body. It sounds funny, and I can imagine convincing yourself that you're not having that experience or that there's no damage there is probably harder than going through something else that you experience, and there's an evolution to that. And
Right.
through that evolution, you find some relief.
Exactly. Yeah. So we do. I think it's both experiential and cognitive,
Uh-huh.
but we leave, like you're saying, the cognitive piece toward the end. We do the experiential part up front, not provide a whole lot of information,
I see.
and we don't get into arguing or debating. Really, we say this is our model. We present it, and then let's try this thing here and see if it helps you, see how far it takes you. And I say, and I'm able to say this now at this moment, that the last group, we started with 6 people in the group, and 3 of them at session 8 had a pain score of 0
Wow.
at the end. And we can't guarantee that, but 3 people did not have total pain relief. But we can see how far you can take it with your experience.
It's pretty
Well,
profound.
there aren't a lot of therapies right now in pain management that brings, pain level from a 6 to 0,
Yeah,
right?
Yes.
Especially in chronic pain.
right,
Yeah.
right.
Do you think the writing things down, writing this process down, that's particularly helpful?
I think that it's helpful, yes, sometimes, but I think that when patients start doing it at the beginning of therapy, it's really useful to have guidance because they can get sidetracked into the fear aspects, into the aspects that maybe are not going straight through this sequence of emotions and get kind of hung up and stuck on that. And you don't want them stuck on a part that's going to make them more scared or more uncomfortable or more. We want to do a process that's going to kind of change this experience for them, be something new, something different, and so they can often benefit from some guidance of that, and then they'll be equipped. They'll learn. We hope they learn this, and then they'll be equipped to do the writing.
Yeah,
and
they have their own
everything.
skill.
Yeah.
Have all the people in the study gotten the medical evaluations for if it's low back pain, discs, and MRIs and things like that, or this is all comers with pain that's greater than 3 months?
Yeah, so we actually do have that criterion for the study inclusion criterion wide open. So many of our veterans have had extensive workups, multiple surgeries, lots and lots of prior diagnostic and therapeutic procedures by the time they get to the study. But what we're trying to do, more than rule out all of the body-based causes, is we're trying to rule in these playing a role.
Yeah.
And the more we can rule it in is really to see how far we can take it. So this is kind of a diagnostic procedure as well as and a prognostic procedure as well as the treatment.
Well, do you find that, we'll talk about the results in a few minutes, but how far you can push someone in a single session predicts how well they do?
So people who, there was one study that colleague Doug Giafruda did with he did one group and he did extensive interviews with all those group members. He found that the patients coming in, buying it, if you will,
right.
from the top, they did the best. And there was a second group of, it was about a third of the patients, they could be persuaded by trying it over the course, and they did kind of moderately well. And then there were a couple of patients in this group that wouldn't take it up.
Mhm.
And obviously the patients who wouldn't buy it, wouldn't try it, they did not benefit as much.
All right, let's go through the results.
Let's compare it to, so what did the CBT, the cognitive behavioral therapy comparison group look like?
So we used a manual that is actually, I think anybody can access it, but it's put out by the Department of Veterans Affairs, and they have trained clinicians, mostly psychologists, also social workers, and some physicians and psychiatrists in this manual. And so it involves skills training primarily. And so the cognitive behavioral model is that pain can come from a variety of causes, and they're more agnostic about what the cause is of the pain, whereas we're really trying to prove over the course of the therapy about the brain and emotional causes and influences. And every week they learn different skills in CBT. So it's things like guided meditations, progressive muscle relaxation, pacing your activities, setting SMART goals for yourself. So really practical and useful stuff.
And in prior literature, had that shown efficacy or?
Yeah, so it's absolutely an effective treatment, CBT for chronic pain, for veterans, for non-veterans. The quibble that some of us have with it is, what about the size of the effect? How many people get a large amount of relief from learning those skills? And it tends to be that the average patient does not get a huge relief, but more of a small. Cochrane review was published, a very large study of studies in 2020, said that it produces small to very small
Effects.
for people. And so part of the whole EAT and a couple other therapies like EAT, I think, can we give patients a bigger response? The brain really is playing a causal role in some kinds of pain, and it's key in every kind of pain. We should be able to do more and give people more relief.
Yeah. Okay. So here's a couple of the main results. Maybe just walk us through these figures.
Sure thing. So the figure on the left is comparing the severity of people's pain at baseline at the beginning of the study, and then 10 weeks is the end of the group, and then 6 months later, 6 months after the end of the group. And so we see the EAT lowered the pain more. It lowered it about 2 points more than the CBT for chronic pain. And that was at the end of treatment. Now, all the way out at 6 months in this medically, psychiatrically complex group of veterans, they did not all retain their benefits. So that should be noted. From 10 weeks to 6 months, on average, the pain got a little worse in the whole group of EAT patients, but it was still significantly lower than the group of patients with CBT.
It got a little worse than their best point, but still lower than their baseline.
Exactly. Yes.
And so the scale that we're looking at is what here?
So it's a 0 to 10 pain scale that probably everybody is familiar with. But what we did was we did 4 different 0 to 10 pain scales. And so it's your least pain over the last 7 days, your worst pain over the last 7 days, your average pain over the last 7 days, and your pain level right now. And so we thought that was a little more rigorous than just, a pain. What's your pain right now in this moment? So that's what
So
we're
you
looking at.
averaged all 4 of
those
those
4.
scales together? That's really interesting.
Yes.
And were they provided any kind of follow-up treatments or therapies that they could do at home after that 10-week mark, or were they just said?
Both of the CBT and the EAT protocols had homework assignments, had handouts for after the end of the session of session 8, but there was no further contact or check-ins between that. So that's one thing that we're talking about, is maybe do they need booster sessions,
I was just going to ask that.
slowly go down in the frequency a little more.
So the CBT group, did this behave similar to what you see in the literature in this Cochrane review, in terms of small but potentially significant effect of CBT?
Yeah, so the Cochrane review found that CBT reduces pain approximately half a point on a 0 to 10 pain scale. And we saw it reduce pain from baseline to the end of treatment by 0.6
Okay.
points.
All right.
So,
So it's pretty consistent with the literature at this point.
yes.
All right. So in context of that, it looks like EAT had a massive effect. It's hard for us to put into context what this actually feels like,
Yeah.
given pain's so subjective, and we're talking about a 10-point scale. But maybe put this into perspective for other types of therapies. CBT drops at about half a point in the literature. What about medications or procedures or other forms of psychiatric therapies?
Yeah, that's a great question. So the other psychological therapies that are standard, like people like acceptance commitment therapy, mindfulness-based stress reduction, these types of treatment are very consistent with the effects of CBT. There have been head-to-head comparisons of CBT with some of these other psychological therapies, and they show roughly equivalent. Another interesting one is pain reprocessing therapy that has not been directly compared with CBT in a trial. There are studies underway doing that, but it also tends to show a larger magnitude of effect in the one study that has been published in that therapy.
What does that involve? Pain reprocessing?
So pain reprocessing therapy is very similar in terms of it's an experiential component and a lot of focus on patients' beliefs about their pain, what's causing their pain.
Sure.
So focusing on patients understanding pain really comes from the brain. And a key aspect of pain reprocessing therapy that I'd say is different from EAT, they try to select patients that really have that centralized or neuroplastic pain so that the patient is kind of on board with that diagnosis at the beginning of therapy. And then it's really trying to address fear of pain and fear of movement to try to eliminate their pain.
So in that vein, I assume, just based on looking at the error bar or whatever the confidence interval is around these data points, that there was some spread in response rates. Were you able to predict that with fear avoidance ratings or pain catastrophizing ratings, some psychological variables that might make people more amenable to this type of treatment?
Yeah, so with EAT, we actually found that people with higher baseline depression, anxiety, and PTSD scores were more likely to have greater pain reduction at the end of EAT. And I really think like what we showed about the way the slide works, pick a stressor and let's start working with it. People who came in with some level of distress, with some level of emotional distress, that they were able to take it right up and engage with it a lot better. That's what we found.
That's fascinating.
Yeah.
Do we know the opposite, not in the context of therapy, but that people with higher anxiety, depression, PTSD scores tend to rate their chronic pain a lot higher?
That's a good question. We didn't look at that in our study. Yeah, so I'm not quite sure on that, but I definitely think that they're mutually influential, so it wouldn't surprise me. Yeah.
And then another way of looking at the results. Just
Correct.
walk us through this.
This is response rates. So in a lot of like drug trials, they look at at least 30% reduction in your pain as a metric of response, like the person responded to treatment. And so that's over on the right side of the right hand graph. And you see the greenish bar, the taller bars, were EAT. So by the end of treatment at 10 weeks, 63%, nearly 2/3 of the patients had a response.
Some sort of response.
Yeah.
Of 30%?
30% response.
At least 30%, improvement in pain. And that was significantly better than CBT and also at 6-month follow-up. And then
So this is kind of meeting the standard of
minimum
what
benchmark,
means minimum benchmark
that they
of
improved.
clinical improvement. And this seems staggering. This seems like a big difference between the groups. This is headline worthy, I imagine. And I know that the results of this article were covered in a lot of different media. But is that what people picked up on?
Yeah, that's in there have been several articles written about the study, and that's the main thing that they focus on, that it was 63% improvement at post-treatment. among patients in EAT versus only, I believe it's 17%
Wow.
in the CBT group.
And I mean, still some 40% retain that 30% improvement
At 60
at
six
6 months.
months. Yeah.
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 And all of these are significant differences. When you look at 70% improvement, still the EAT group had a significant
Well, those are
difference,
actually
right?
not significantly different.
No?
Just the 50% improvement
I see.
is, yeah, because the sample size was just too small on the
Uh-huh.
70% improvement. But you can see there were numerically more
Yeah, yeah.
responders in that category in
And that's a
EAT.
massive amount of difference improvement.
Yeah,
wise.
we're taking that to mean, again, these are veterans. They've
promising.
had over 20 years of chronic pain.
Right,
We're
right,
taking that to mean pretty much total resolution of their chronic pain.
Yeah.
Yeah.
You mentioned sample size. What was the sample size for this?
The whole study was 126,
126.
patients at
Yeah.
one site. So
Yeah.
it's still a smaller study.
Yeah.
We're working on bigger studies.
Yeah, so that was going to be my next question. If we're done discussing the results, is what's the next direction for this? Or do you want to keep talking about the results?
Yeah, I got one more slide just
Okay.
to cover. I think maybe you've already outlined this, but
Yeah.
in graphic representation.
This is what I mentioned. It kind of hurts the eyes. It's
Yeah.
kind of hard to look at, but it's saying what I mentioned earlier, that if the person had a high, if you look at panel A, a high baseline score above median is like the middle, like it's a measure, a high score in EAT, they had greater pain reduction than if they had a low score. That's what the lower line means with the big slope. Whereas in CBT, there was not really a difference. If they had low depression, high depression, they were about the same in terms of their pain. And the same phenomenon with anxiety and with PTSD symptoms. Higher symptoms predicted better response for EAT.
Yeah. Incredible.
So these things interact.
Yes.
Yeah, I think, Daniel, you were going for what's next?
Next steps.
Next steps.
Because you mentioned sample size, we're thinking about bigger studies. Obviously, this is something that you're going to dig into further, considering the results, right?
Yeah, so we're currently doing a study in older veterans that's entirely virtual. So this was actually in-person groups where we were in the room together.
Yeah.
So we're doing groups virtually now, and we're using veterans from 2 sites, so in Los Angeles and VA Connecticut, and we have added a mindfulness comparison group. So it'll be comparing EAT to CBT again and to mindfulness. So that study's about halfway through.
So 3 groups.
Yeah, so it'll be three different groups.
And the mindfulness group is MBSR or?
So it's actually MBSR is not something that's widespread in VA settings. So it's a VA format of mindfulness that we got a hold of, and we actually have the developer of that as a co-investigator on
Cool.
the study.
Nice.
So you guys argue over who's going to win or
No, we're all
agnostic?
collegial,
Right.
and
What-
we'll see how it
Do you have any updates in terms of you're in the middle of this study? Are you able to provide any updates as to how things are looking? Or
No, not. We don't have any planned analyses for the midpoint of the
Midpoint.
study. So
Okay.
yeah, we gotta wait till the end.
incredible.
Yeah.
So 3 groups, all remote group sessions.
Right.
And how large are the groups? How many sessions?
Yeah. So our group size is a maximum of 6.
Okay.
So we have to keep it on the smaller side because we want to give that personal attention to each of the patients, like I mentioned earlier.
And how long does it typically take to get through a session?
It's 90 minutes. So we have one-on-one with each patient prior to the start of the group, and then they go in the group, and that's 8 weekly sessions. Each one is 90 minutes.
Yeah.
Seems doable.
Yeah.
I want to shift. Kevin mentioned medications, how this compares to medications, and I mentioned opiates before. I mean, it's a big issue. Again, another issue you can't ignore in the context of chronic pain. What are your thoughts on opiates? Can I provide my thoughts?
Please, yes.
So
that'd be good context.
So I prescribe opiates, and I don't particularly like doing it, but I do, and I'm very selective with my patients. So that being said, after our conversation today, I think that opiates are potentially contradictory to a lot of the things that we've talked about today that, might improve someone's chronic pain or potentially be protective against chronic pain, like self-efficacy, for example. What are your thoughts on opiates, how they interplay with chronic pain, and how they relate to what we're seeing here with your results?
Well, not to be too controversial, but I mean, my bottom line is I'm against it.
Right.
But I'm a psychiatrist, so I think maybe my experience is different from yours in that I'm not really usually in a setting where people are asking me personally to prescribe opiates. So it's kind of talk is cheap for me to say because in psychiatric settings we don't really prescribe opiates anyway. They go to you, unfortunately, for opiates. But yeah, I think with every they have a role, and I think guidelines say they have a role perhaps in acute pain issues, like when somebody has a surgery.
Yep.
And they can have opioids for a limited amount of time. But there's so much evidence showing that they are causing more harm than good in chronic pain, basically. And I hear things like, oh, well, we'll give patients opioids if they have evidence of pathology. And this is playing into that message that I think is not supported by scientific evidence that, oh, well, if there's some injury in the body, then the pain is real and they deserve opioids. Whereas if there's no evidence of injury, then pain is not real. And so this is just a tired, outdated way of thinking in my understanding. And I think we really need to move beyond opioids, I would say, as a treatment category that we really consider, because like you said, it can have effects of blunting affect, of harming self-efficacy. And a large study, famous study, 10 times more articles of than my study in the VA a few years ago compared opioid and non-opioid medications. No difference in disability, but people's pain was actually higher with opioids than with all kinds of non-opioid pain medications. So it really is, I'm hard-pressed to find good indications for them in chronic pain.
The idea that the brain has such a big role in the experience of pain, and that if we access the brain with these different therapeutic approaches, whether it be mindfulness or cognitive behavioral therapy or EAT, they can have different effects on the experience of pain is, I think, exciting and interesting. And what I'm picking up is there's a dichotomy between the therapies on the experiential level. And I've always thought this without having a ton of knowledge about the literature in regards to experiencing something viscerally or emotionally with a physiological, psychophysiological state change is a completely different bottom-up and some top-down experience rather than just thinking about it differently. It is hard to, again, I said this before, but think differently. Like, for example, catastrophizing about something. I get a migraine or it's percolating as I'm, trying to run on the treadmill. How can I not think that that's going to ruin my day? There's pulsation behind my eyes. I'm starting to get nauseous. If I miss my workout, then I'm worried that I'm going to start to get out of shape and I may never be able to really catch up again. And I'm a dad, I'm busy. And so you start to go down this rabbit hole of catastrophizing and rumination that it's hard to talk yourself out of.
Yeah.
But I imagine having kind of recalibrating, almost as you said, with the reprocessing therapy, the emotional system and how it is tuned to react to stimuli and to maybe normal everyday emotions is probably part of what's happening there. I'd be interested to look at functional MRI in reaction to certain emotional stimuli before and after EAT.
Yeah, absolutely. Yeah. And I think just responding to your example there on the treadmill and the catastrophizing, I mean, I'm totally in lockstep with any CBT therapist, any kind of psychologist would say that's not healthy. I mean, it's not healthy. And I think what you're pointing out is how do you get the person out of that, though? And so what we would try to do is try to look at how painful that is and try to facilitate an emotional experience, some sadness, some grief over that kind of thinking that is torturing you, that will touch them, touch their heart, and that kind of experience would help them to let it go much more easier rather than trying to debate it
Yeah.
in some way. But yeah, I think the CBT tries to be experiential as well. I mean, so I don't want to give them short shrift on that as well. They do experiential things like progressive muscle relaxation and guided imagery. These are aspects of CBT, and I think those are very helpful skills. I think we can do more at the same time, and that's
So you
kind
think
of what we're about.
accessing the emotional system is really the main difference?
And that's one difference. And the other difference is, I might say we're a little bolder in terms of saying, no, what we're doing, we can reduce your pain. We can give you pain relief. We can perhaps eliminate your pain together working in this way. I think there's a lot of hesitation out there sometimes, especially in light of a lot of multidisciplinary teams where you're working with physicians who may be giving a different diagnosis than you're giving as a mental
Sure.
health provider.
Right.
There's a lot of kind of everybody hedging their bets in terms of what you can do here. And we take the patient, we bring them in the group, bring them in the room together and say, let's just see how far we can take this. And we want to have that bold attitude. I think that really is powerful with these patients.
Is what you're trying to get at, that hurt scenario, does that have to be related to whatever pain it is that they're having, or is it separate from that? It's just like, give me a hurt scenario that's on your mind or that happened recently. Is that what's happening?
And let's see how it affects your pain. Yeah.
Wow.
We're working through the pain of their life. That's what we're working through, and we're seeing how that affects the pain they experience. Yeah.
I wanted to go into a couple other types of therapy, just to understand the brain's role again in pain from a different angle. So biofeedback, neurofeedback, is this something that can be effective? Or are there other things like empowered relief, the Stanford-based program that, from my understanding, there's been studies showing that 2 hours of psychoeducation generated remotely or viewed remotely can have benefits as compared to a little bit weaker control groups than yours. But what are your thoughts about
they
these?
use the same control group
They did
as
a
mine.
CBT?
Yeah. So yeah, and I love empowered relief. I think it's fantastic, and the idea they showed improvements in pain catastrophizing. That was their outcome. Their primary outcome was equivalent, like, to a full course of CBT.
Just 2 hours of a video?
Right. The issue
Amazing.
with it is we saw what's the level of outcome from CBT. It's a small magnitude outcome. So we're still dealing with small magnitudes, and the fact that you can, get maybe a lot more with a more intensive form of psychotherapy, that's kind of what I'm about. And I think the same thing with biofeedback, like paying attention to your experience and seeing how you can affect it is good. But I think going deep, right, into the pain of somebody's life is potentially going to give you more. So none of these things, I'm critical of none of them.
Sure,
I think
sure,
they're
sure.
all great, but it's just like, how big are we able to achieve an effect, and for whom, who is willing to do what.
Yeah.
And pain catastrophizing, which I have the scale here for
Yeah.
you guys, is it's a mechanism for amplification of the pain experience rather than pain itself, right? It is something that could be, just like the other processes we talked about, a segue to experiencing pain more often or more intensely, out of proportion for what the structural injury might be at the moment.
Absolutely. Yeah.
So there's three categories: rumination, which is overthinking things; magnification, amplifying the experience; and a feeling of helplessness, which I would say is the counter to self-efficacy. But that's an interesting scale, and it brings me back to
And it's interesting. It predisposes to post-traumatic stress disorder.
it is
Helplessness and lack of
involved with
self-efficacy.
migraines. It's
Yeah.
involved with post-concussion syndrome or
Yeah.
persistent post-concussion symptoms.
Definitely.
But again, you get Marcus Aurelius talking about this. Pain is neither unbearable nor unending as long as you keep it in mind. As you keep in mind its limits and don't magnify them in your imagination. And so, thinking through that, I mean, it's hard not to, especially when it lingers or
Yeah.
when it interferes with our daily routines. It's pretty profound.
So what I'd like to hit on is some takeaways for anybody watching this. If they're dealing with chronic pain, how should they approach their pain at home, not necessarily having to undergo this kind of therapy? What kind of approaches or perspectives would you impart on anybody for dealing with chronic pain?
Yes, and so I mean, I just want to say, like, who am I to argue with Marcus Aurelius? but I don't know about people taking the word imagination the wrong way
Sure.
in that quote, because I think for me the biggest takeaway is that pain is not imaginary, and the fact that you're having chronic pain that's lingering and lasting, the pain is real. If you're feeling pain in your back, it's in your back. So we are not here saying that it's not, right? That is real. That is happening. And the question for everybody to really think about is what's causing it? Why is there pain in your back? And is that because there is damage, disease in your back? Maybe in some cases. Maybe it's one contributing factor, what's going on in the back. But the big contributing factor is likely the brain that can cause pain out of nowhere. It can. And it can amplify lots and lots of forms of chronic pain and perpetuate them, maintain them. Catastrophizing is one way in which they can perpetuate and affect the pain experience through the brain. And then the second thing is your brain is really shaped by your life experience and the way that you learned to deal with your life experience, with stress, with relationships, with conflict. And so because your brain is shaped by those things, we can shape it differently by processing stress, by processing trauma, by helping you get through it, overcome it, move past it as best as any of us can. That can literally get you feeling different and change your experience of pain. So I would say there's hope for people. It is really inside of all of us with people who have chronic pain. Like, they are their best advocates. They are the people who are suffering from the pain, and they can provide themselves with answers to try to get themselves some pain relief.
Yeah. Good. You gonna do 3, 2, 1?
Yeah.
Yeah.
So we usually end with a 3, 2, 1 closer. So that's 3 truths. You just kind of outlined a few, but and then 2 fictions about pain and 1 thing anybody can do anywhere today to help themselves or relieve pain.
Yeah, so I think the 3 truths, I would piggyback on what I was just saying, that all pain is real. There's no such thing as imaginary pain or fake pain. And all pain is really a consequence of the brain, right? Any kind of experience of the pain. And the third thing is that really the brain can cause certain types of chronic pain. That we can get out to. And so the fictions are that pain is imaginary or made up or People are lying. Maybe some people really like, the people with the neck braces we've all seen, but this very, very small proportion of people, not the kind of people that I see that are coming to me as patients for help. And the idea that pain is in your head is a fiction. So it's not in your head. It's where you have it, but it's what's causing the pain is really the question. And what was the last thing?
One thing anybody can do today to help themselves with pain.
I definitely think allowing yourself to be who you are, feel what you feel your true and honest feelings, even if they're those ones that we talked about that are more difficult for us, like anger, or if you feel guilty, or if you feel sad. These are important feelings, and just allowing yourself, giving yourself the space, the kindness, the compassion to feel what you feel, I think can take a huge burden off your shoulders, off your back, and get you feeling better.
Incredible. Dr. Yarns, thank you so much. I really appreciate it. I think what we've been doing thus far in terms of our treatment of chronic pain has definitely not been working. So it seems like we definitely need a paradigm shift when it comes to how we think about pain and then how we treat it. And it looks like you're kind of leading the way there. If anyone's interested in following your work, where can they find you?
Well, I do have a YouTube channel that is very small and just starting out. That's at Brandon Yarns MD, and I'm on some of the social media, I think, under that same handle.
Mm-hmm. Incredible.
Yeah.
Anything else?
This was awesome. Thank you for coming down. We really appreciate it. I think we're of the same mindset, but still there's a lot of work to be done, and I hope that many people out there will listen to this and feel that there is hope and that there is the potential for benefit by thinking differently about pain and experiencing their lives more fully. So I appreciate you.
Thank
All right,
you.
everybody. Thank you for checking it out. But most importantly, be better.